Hello. Thank you.
Hello.
Hello, folks. Thank you for your patience. Had a couple technical difficulties.
No problem. We're all just excited to be here. Look at Jackie.
I know
She's
I
about to jump
am.
out of her chair. She's just ready to go. Adam just got done doing back walkovers and cartwheels.
Some light trampoline work on my lunch break. Yeah, exactly.
That's the spirit.
Perfect. Can everyone see group agreements okay?
I can see him.
Perfect. All right. I think we have enough for quorum, if
Okay.
I am counting okay.
Do you want me to start with group agreements since they're up?
That would be great, Jackie.
All right. So be present and participate to the best of your ability. Treat others with respect. Try and avoid interrupting and use the name pronoun the person prefers. Avoid acronyms. To use the chat to write down definitions or ask for clarification. Varied and opposing ideas are welcome. Be curious when the disagreement occurs. Honor those who's quiet with quieter voices, lean in or lean back. Avoid problem solving for individual situations. Connect offline if possible. Focus on our purpose, improving the system of care for Oregon. Be mindful of the power dynamics in the room and do your best to avoid harming others. Be open to repairing harm if you may cause. So these are our group agreements. This is the data and evaluation committee. And now I'm gonna move on to roll call. So I'm Jackie Serrano and I see Andrew's here. David Ratu and Adam Rodakowski.
David is going to be late today.
Okay.
Adam is present.
Chris Barnes and Amber Kramer.
Chris Barnes is here.
Amber Kramer is here.
Great. Bonnie Cracksberger.
Yes.
Okay, I got it. Okay. And Brianna Neely.
I'm here.
Great. Will Burchard and Hillary Harrison. So
I'm here,
sorry.
thanks.
Okay. Is Hillary here? Not yet. Okay. Chris Kuhn and Piper Block.
Hi there, I'm Grace Pava. I'm attending on Piper Block's behalf.
All right. Thank you, Grace. Samantha Kahn and Jen Corbridge.
Jen is excused.
Okay. Alyssa Cox and Mark Hammond.
Mark is excused.
Okay. Isabella Jacoby and Mark Greenwald.
I'm here.
Mark's here.
Great. Steve Westberg and is it Margot?
Margot.
Margaret's
Margot.
here.
Great. Becky Marshall and Gretchen Morley.
This is Amanda Rivers. I'm here for Becky Marshall from the data team.
And Gretchen's here.
All right. We have some open seats, but thank you all for being here. Um, all right, are you putting up our agenda next, Cody?
Yes.
Okay,
Yep.
great.
Thank you. Working on my tech skills today.
Yeah, look, Ann is here, but it just says SOCAC NT. I think she's incognito today.
She's hiding. All right. We seeing the agenda?
We are now.
Yes.
Perfect.
Okay.
All right. Andrew, I'll give you a quick intro here, just so folks can have a little context into what we're going to be going over today. We are tasked with giving a update on our measures to the legislature. I have been working on what that measures update looks like. We bumped into a couple issues with methodology that we're going to be talking about later today, and then kind of reviewing as a group what direction these measures are headed in. And again, these are our strategic indicators that we have in the SOCAC strategic plan and some of our process measures too. Before we dive into those, I know a lot of folks have not been as involved with the creation of those measures. Andrew Grover, our co-chair, has been involved in pretty much the entire process, I would say, Andrew. So he's going to give us a bit of a recap into how we got to these measures. And then the plan is for me to overview what the update looks like. And then as a group, we'll vote to approve this to include in the legislative measures update. So we actually get to have a vote today, which is fun. So make sure your Zoom hands are ready for later to either approve or not.
Everybody's white knuckling it, ready for that vote. Should I take it, Cody?
All yours, Andrew.
Okay. So is it possible for me to share my screen? I think I have
Yes.
I have the share button. Okay, so I'm gonna just go ahead and do this. Oh, now it took me somewhere else, but you guys should be seeing the system of care, kind of the plan, the system of care plan that we've got for the next several years. Everybody seeing that? And so along the right here, first I got to figure out how to pin that. There we go. Along the right here, first, we've got these goals. We've got strategies to go along with those goals. This is the summary document. And then we've got some results and outcomes that, we want to be keeping our eye on along the way. That's pretty much the basic construct. So, what I would suggest is that these results and outcomes, at least for the foreseeable future, are things that we are monitoring. I don't think we've got enough in play to say that this thing that we're going to do or that thing that we're going to recommend is going to impact this measure or that measure, but they're things that we're monitoring. As a way of sort of getting the pulse of how the system of care for youth and young adults in Oregon is functioning. So that's sort of contextually kind of where that is. The way we got to these results and outcomes, this was in the run-up to our system of care plan. This committee, last year and even a little bit the year before, went through a whole process where all members of the committee sort of came and suggested measures that had data that were publicly available on intervals that we thought were reasonable and helpful, and that were targeted enough that it measures the kinds of things that we want to measure. It's not necessarily, if we were to all sit down and say, what do we really want to know? How do we want to measure whether or not kids, families, young adults are better off because this system exists than if they did? We would probably draw up a more ambitious set of measures, but those kind of data, even though we can conceive of them, they're not necessarily available, publicly and on the intervals we need. And, maybe we could get a point in time study of something, but then we'd have to do that again every year. So, we went through that process. We kind of pruned through. We had a list of probably 60 or 70 things. We kind of went through it and came up with this list here. some of it has little subcomponents. And when Cody is going to go through the data that he has on where the system is on all these measures, as soon as I get done talking, some of them have little subcomponents that you'll notice. So this one here, increase the number of youth receiving treatment at home and in their communities. We basically said, okay, there are 3 or 4 sort of levels of care or services that we want to make sure we're seeing the kind of availability, access, kind of growth that is out there. And so you'll see in the report, those are there. And then others are just sort of a single measure. So that's what you'll see as Cody goes through it. But from a contextual standpoint, that's the starting point. So I'll hand it over to Cody unless somebody raises their hand and says, well, that's stupid. Why did we do it that way? Or something like that.
Yeah, any questions on kind of the process that led to the initial measures? And we will be talking about the potential measure changes next month. We'll have a little bit more time for discussion on that, but this is more focused on the measures update this month, just with the timelines that we're dealing with.
Just for the record, I mean, I do think and hope that these things can evolve and that we can do some kind of supplemental measures as we learn more, as we grow more, as we have kind of resources to maybe even study things. I don't think this personally, this isn't my decision by myself, but it should be sort of etched in stone for 4 years. This is what we're doing, because I think we'll learn a lot. And we'll have different opportunities to measure things along the way. So, but it was the best we could do with the group that we had. I think it's a decent starting point.
Thanks, Andrew. I just put this in the chat, but if you would like to follow along while I share a screen, the measures update is attached to the calendar invite. I'm not going to go into detail for every single one of these. We have quite a few indicators and process measures. But we do have some, I highlighted some that are either large changes or needed a methodology change. And so hopefully that highlight is pretty clear on the areas that we're going to be looking at a little bit more intensely in these next 15 minutes or so. And then we'll have some time to discuss, answer questions, and then vote as a committee. Okay, can we all see measures update for data and eval review? Yes, perfect. Okay, before we start, this measures update is quite a bit of work, most of which is not me, but is relying on our system partners. So thank you to folks over in ODE, ODHS, Child Welfare, Juvenile Justice, Intellectual Disability, and OHA for helping compile this measures update. It is not a small task to do, and so just wanted to extend a thank you out to those partners. Our first couple indicators come from the Oregon Student Health Survey. The changes are pretty minor for safe place of person outside of school between 2024 and the current data in 2025. We have this structured to look at what was the percent in 2024, what was the percent in 2025, and how much did those percentages change, and did they go in the intended direction that we were looking for? And then we have a very brief conclusion. I want to talk about why these aren't broken down into a lot of crosstabs, and it's just the basic level of measure. So for us at SOCAC, we are focused on all of Oregon, and specifically kids that are involved in multi-system. But for these measures, the justification for not going deep into crosstabs is that we are looking for all of the youth that are impacted by this, not specific sets. And if we were to dive into each of these crosstabs, we're getting outside of the scope of looking at every kid who's at risk for us in our population.
Cody, can I add a maybe a friendly amendment to that in terms of how we think about it going forward? When you say crosstabs, I think you're talking about like subpopulations.
Yes.
And so I do continue to think that we should be moving in the direction of being able to stratify data based on certain demographics, race, ethnicity, geography, things like that. And I know some of these data elements maybe don't lend themselves to that, but wherever we can, we should, because what you just said is 100% true, and there's only so much we can do. But also we run the risk of were you responding to me? We are not.
Oh, no, sorry. I was
Okay.
responding to David's question. in the chat, Andrew.
We run the risk of kind of universalism, when we say, here's the number for everybody in the state, but there could be significant subpopulations that are suffering much more than others. And we just need to kind of keep that in mind.
Thanks, Andrew. And David, we did consider doing statistical analyses for these, but it's not necessarily the purpose of this report. This is mostly a what direction are the numbers going, more so than statistical analyses on changes over time. There are folks that are doing that work with that level of statistical significance, but for what this is going to be used for, which is framing our legislative update, we didn't necessarily feel like the statistical calculation was necessary, more so than just what direction are we headed here in this first year of updates. If we disagree with that approach as a group, that's okay. We can talk about that too. But that was a decision that was made to focus mostly on just what direction are we going here.
I guess I'm just wondering how you answer that question if you don't apply a statistical test. Like in this example, so yes, it's down 1%, but like, is that within the margin of error? There's no confidence interval. How do we even say that that's a decrease?
I agree that it could be within the margin of error, David, and that's part of how we're going to be writing this out. Is the number changes so small, this likely isn't anything to do with what we're doing because it's such a small change. But if that becomes a large focal point today, when we get to it, I'd love to have that discussion. But point heard. I'm going to scroll down here just to get to a couple of the highlighted points. One of our other measures here is from NISDA. They just released 2025 data, and I don't have it included because it just recently came out. But these are, again, pretty small or negligible changes between 2022 and 23 and the 23-24 sample. We did see a pretty sizable change in specialized home and community-based services, specifically for intensive in-home behavioral health treatment. The amount of youth receiving intensive in-home behavioral health treatment went up from 275 youth in 2024 to 465 in 2025. It's about a 70% jump up. And again, one thing that we don't control for here is the total number of youth in Oregon. There's a lot of other factors that aren't controlled here. It's just looking at raw numbers and raw changes over time. We have our behavioral health treatment foster care, went up about 11.3% of youth, but pretty small sample here as well. We don't quite yet have our mobile response and stabilization services. Those data are waiting to be pulled from OHA. They bumped into a validation issue, and so we're hoping to have those somewhat soon, but they might not be available for 2025. Number of youth enrolled in our Fidelity wraparound services at the end of the year went down by about 15.5%. So fewer youth there. Oh, Chris, I see your hand up.
So I'm going to say that what I have seen and is that in several of our larger counties, they are pushing kids, not forcing, obviously it's family voice and choice, but there is this increased, let's do IIBHT over wraparound. So just letting you know that that could also be where our RAP kids are going.
Thanks, Chris. I will note that when we're going through and making edits here.
Yeah, those are two, pretty different services. So it's interesting that that's the take on things in the community you're talking about.
And Cody, I need to contact you about that wraparound number. I just queried it internally and someone's double checking some numbers because I was like, this doesn't feel right. So I'll let you know if there's a problem.
Okay, thank you.
But thank you for doing it, because it's only when you put year next to year that you suddenly go and ask more difficult questions.
Yeah, that would not be the first time that this has come up. We'll get to one of those interesting year-to-year comparisons a little bit further down this doc. So for ED boarding, the ED boarding is undergoing a few changes at OHA, and Hillary, feel free to jump in if I say something that is not accurate or if I'm misrepresenting this. Our previous measure that's included in the published strategic plan for ED boarding is calculated only using primary diagnosis codes for mental health and substance use. OHA is reworking this measure to include any diagnosis code, not just primary diagnosis codes for mental health and substance use. And so these percentages from 2022 to 2024 have been updated to include the new calculation. Obviously, that's not included in the published version of the strategic plan, but these numbers here are consistent from year to year with the new calculation of the measure. Perfect. Hillary, I see a head nod, so I'm giving myself a pat on the back for explaining that.
I think you got it. Yes.
Perfect. All right, for high school completion, we don't yet have our 2025-2026 data, and for this measure, we started in 2024-25, and our strategic plan is our baseline. So this won't be able to be calculated until the next measures update. Suicide attempts, pretty negligible percentage decrease here from 3.4 to 3.1 within our student health survey. Our secondary measure is hospital admissions or hospitalizations for self-harm and or suicide attempt related diagnoses. That went up by about 4% from 2024 to 2025, but we included 2023 as a reference if folks wanted. Okay, I'm going to spend a little bit more time here on downstream system involvement because this I think is a little bit more complex of a conclusion. This is from our system of care dashboard. And just in our percentage increase and decrease in system involvement from 2024 to 2025, fewer kids in child welfare and fewer kids in juvenile justice. However, the kids that are in 3 or more systems has gone up by almost 10%. We don't have an intended direction for 3 or more systems, and I'll talk a little bit more about that in a second. But I wanted to show the combinations of these 3 or more systems to show where those changes are coming from. The changes are not coming from combos of child welfare and juvenile justice. They're coming from more youth getting IDD and behavioral health services. So our more downstream combinations of services, specifically child welfare, juvenile justice, and behavioral health, or child welfare, juvenile justice, and IDD, those went down from 2024 to 2025. And so this 3 or more system involvement is being driven mostly by an increase in behavioral health and IDD services. Mark, I see your hand up.
Yeah, I was just going to mention that makes sense, right? Because I think one of the earlier charts showed there was a significant increase in the home-based behavioral health services, and so it seems like it would jive. And that the juvenile justice numbers do make sense there because we do have fewer kids overall, particularly at our end.
Perfect.
Hey, Mark, has that,
any other questions?
I'm sorry,
Go ahead,
Cody.
Andrew.
Yeah, Mark, has that trend been happening for a few years?
the pandemic makes it a little challenging. And so the state was trending kind of down slowly. Then the pandemic was the largest drop in crime ever, right? And so we've been kind of coming back up, but we're still below where we were in 2019. And so do we have more kids? Yeah, but when you look at the longer term picture, we're really still on that downward trend.
Okay, thank you.
And I expect that with some of the changes, improvements we've been making at OAA, our population is going to get smaller because we're going to try and be more efficient, serve youth more in less time. And so that'll bring the numbers down as well.
Helpful, thanks.
Thanks, Mark. If folks notice this, we do not have an intended direction for multi-system involvement. Some of these systems are necessary, and we have a little write-up explanation for this as well. But you can think of like a kid who needs behavioral health services. If they get those services, that's not a negative for the state. That's a positive, even if it means like kids involved in more than one service. And so this isn't one of our measures that we have an intended direction on. We're more so just monitoring any significant changes, not statistically significant, but any large scale changes to the system over time. Okay. Family experience and reporting a well-functioning system of care. This stayed effectively the same from the 2023 to 2024 sample. We don't have new data yet, and those are expected in fall 2025. Language services. This is from our CCO metrics report. Sorry, this table kind of spans across 2 pages, but
so can we pause? Can you just pause it right there just for
yeah.
1 second? Scroll up. Yeah. So notice that we're jumping out of the concept of like outcome measures, like what happens in people's lives, to process measures. We're now starting to talk about measuring how the system functions, how many kids are in this place, and what, there's a little bit of overlap in here, but I think that's an important sort of line to keep in mind.
Thanks, Andrew. This went up by about 4.6% between 2023 and 24. They have kind of changed their measures a little bit in changing on reporting from a sample of visits to all members who identified as needing an interpreter. And so that's only reflected in the 2024 column. It's not clear how this will impact our metric yet. I think we'll probably need the 2025 data before we can get a better explanation on that from the CCO reports. For our peer supports, this is from a data request to our traditional health worker registry at OHA, and this is the number of registered and employed peer supports active in a given year. Within the strategic plan, this was a one-time calculation, but it's not clear on which specific day peer supports were calculated. So this measure is changing to be how many were active during X year, being 2024 or 2025. And it's a better indicator of how many peer supports Oregon actually has for youth and for family. Okay, school Medicaid also underwent a bit of a change. The initial calculation that's included in the strategic plan is not as accurate as it should be because it included all education agencies, not just school districts. And so it changed the percentage a little bit to be overinflated in the published strategic plan. The numbers that are included here are accurate from OHA, and the calculation has been corrected, and we'll be proceeding this way moving forward with the actual school districts, not just all education agencies. Oh, Hillary.
Could you go back to the one on peer supports? I have a concern just because there is quite a lot of work going on around peer supports, around the traditional health worker registry. That is not representative of how many peers are actually working in peer support. The number's substantially different from that. People who are in the registry are not necessarily working, and it's an ongoing concern with the Office of Recovery and Resilience around trying to figure out how many of these folks are actually working or not. It's anyone who's taken a course and passed in the last 5 years versus someone who's actually an active peer support specialist.
Okay.
And I think we somewhere need to explain that because just from knowledge of trying to use the registry and the information in it, I'm going to guess somewhere between only a third and a half at best are in the peer support business at this point, if that. But that's kind of a gut feel, and I see Will agreeing with that. But so it's kind of this, I know it's the only place to take data from, but I think it's really important to recognize that sadly it's not maybe that helpful.
That's helpful, Hillary. They were not able to share actual employment data with us
Right.
from here. And so would you recommend just putting that as a note in here while that's worked through?
Yeah, and you might also liaise with the folks at ORR to see, because again, even your support of them getting measurement done might push push over into someone doing some real work to figure out the actual numbers. Because
Okay.
we're all overinflating the workforce at present, and we know that there's still a huge shortage for peers. And
Thanks,
happy to
Hillary.
make that connection for you, Cody.
Perfect. Christy, I see your hand too.
Yeah, I put this in the chat, Cody, but we got some employment data out of the CCO employment or the CCO traditional health worker reports. So we could follow up with those folks as well to see what they have.
Okay.
Do
And we're getting,
do
go
traditional
ahead,
health, do those certificates or whatever they're called, do they expire?
Yes, they do. They run for 5 years.
Oh, 5 years. Okay.
Yeah, but
Yeah,
if
that's a
someone does the
problem.
training and then works for 6 months and moves into something else, they
Gotcha.
don't drop off for that 5 years.
Okay.
Okay. I'm going to keep us moving so that we have time for the formal discussion. I'm going to go through respite really quick. This is from our system of care data dashboard for behavioral health, and then requests to ODHS and intellectual disabilities on number of youth receiving respite in a given year or accessing respite or relief care in a given year.
I'm going to say that having talked about this with the CCOs, the behavioral health number is of concern. Many times it's covered in their global payments, and so they are not billing for respite. And so there are actually more respite services being provided than we're catching in these numbers. And that's an ongoing issue for a whole number of things as to how we get at some of the numbers when we get into these global situations.
Thanks, Hillary. We'll be sure to note that here, and then maybe that's an adjustment we make to the respite measure next month when we have a little more time to make those adjustments.
Yeah.
School workforce. We bumped into a methodology problem here. The initial baseline that was included in the strategic plan, those ratios were pulled from a 2025 workforce assessment that was published by OHA. I went to update these numbers with ODE. They could not validate them. Then I went on a bit of a citation and reference adventure. Realized that the 2025 OHA report is referencing data that are actually from 2015, which is not accurate. And so I reached out to ODE, and they were able to provide us with updated numbers from 2023 to 24 and 2024 to 25 for our ratios. So moving forward, the numbers will be accurate, but within the published strategic plan, the numbers are very outdated and not verifiable. For early intervention, These are from our CCO reporting metrics. This measure started in 2024. We don't have new data yet. So scoot past this one a lot quicker. For decision-making partnership, these are from our National Survey on Children's Health, using our 2022-23 sample and 2023-24. Went up about 6.4% between these 2 years and samples on folks who always or usually partner with providers in decision making. Okay, one thing I want to note before we get to discussion, none of these data were collected after our strategic plan started or in 2026. And so these are still updates, but they're more so updates to the baseline, nothing that we've done within the current strategic plan should have contributed to these numbers. It's more so looking at, like Andrew said, just how the system is doing. And I know there's a lot of content here, but would welcome any discussion and thoughts, particularly revisiting David Ratu's question on how we want to talk about either statistically significant or if it's just trending in a certain direction.
This is the part where people talk, other than Cody.
Yes, I would love a break.
I love seeing all these metrics, but at some point I think I have a hard time interpreting what they really mean, because I think a lot of these statistics are very overdetermined. And I wonder whether on some of these metrics we need to look at them and say, do we have a more precise, more specific way that really gets at what we're trying to find out? Like, for example, we look at boarding in the ED. Is that a measure of worse mental health problems? Is that a measure of less ED staff? Is that a function of fewer hospital beds? Like, there's so many things that and I think there may be, in some cases, ways that we could do more sophisticated metrics that actually help us interpret the numbers a little bit better.
That's helpful, David. And maybe we talk about that when we revisit our measures and are the things that we're including right now good indicators of how the system is doing as a whole? Because I think that's a very fair and valid question. One thing that I know we will not be able to do within these is control for a lot of underlying variables and other factors. The data just aren't there for that. And it turns into a much more advanced statistical and data project, more so than just a simple update on where our measures are. But I'm totally open to doing these quick. I think it'd probably be a chi-squared to look at these percentage changes for our stats folks on the call. But as far as really diving into the stats, that's probably a larger study done by either a contractor or just a different data project.
Yeah, I mean, I think in some cases the data probably is there. Like, getting back to the boarding question, if we looked at the number of kids who were there for more than 24 hours, say as a percentage of the number of kids who went to the ED at all for a behavioral health problem, that actually might tell us more than just looking at the raw numbers, because it would sort of control for how many people are coming in. And so I think that there may be opportunities in there. We just have to kind of think them through a little bit.
Yeah, speaking to, it looked like, I think it was, you had 3 or so higher level measurements. It's like 2 student health survey, 1 substance use disorder prevalence. Am I getting that right?
Maybe. It
In the
kind of
ballpark?
depends on the measure.
In the ballpark?
I think so.
Yeah, I don't know how much you want me to talk like specifically about one of those right now, but the work I do at Alcohol and Drug Policy Commission, one of our top 3 indicators is also substance use disorder prevalence. And we've just done some work around whether we can compare those figures or not, and found like a way of sort of collectively presenting substance use disorder data together rather than just using one prevalence figure. Because I think probably some of these NISDA data are like plus or minus 5 percentage points in either direction of the estimate, and so like putting 2 next to each other can be hard depending on which of those you use. So I'm happy to talk more about what we do wherever that seems like appropriate.
Thanks, Will. That would be great. As much as I would love to say that I am a expert or the expert on each of these data points, that's not the case. That's part of why we have this committee of folks, is because one person cannot know the ins and outs of every single one of these data questions. And so that's why I'm relying on all of us that are here to help us talk through it. And the classic, individually we know a lot, but together we know even more.
Yeah, I would suggest just in terms of the report, it's a very first offering based on an initial set of indicators that were selected. I would suggest that we put a little summary section at the top. Very simple. Most people won't read 8 pages. They just won't. So I'd put a summary in there that just says, first of all, these are 2 or 3 things that jumped out. We don't know at this point if it's statistically significant or not, but they jumped out. There's a lot more IIBHT. There's fewer kids in juvenile justice. We need to do some work on how we collect this or that. And future reports, we're going to endeavor to add the question of statistical significance wherever possible. Kind of something like that. And honestly, most people will only read that if they open this report at all. But this group here, I think we can keep digging in and getting a little better and smarter and faster. It's nothing's as kind of simple and easy as we'd want it to. Like even the emergency room boarding thing that David was talking about. Every hospital collects it a little different. They define things differently. Everything sounds simple, and when you get into it, it tends to get real squirrely. So I do think that we will need to have some sort of kind of third-party contractor do some analyses if we can come up with exactly what those analyses are and what's most important to us.
Chris, I see your hand up.
Thanks. One of the other things I was going to say is that we can't always keep kids out of the ED and many times they go into the emergency department and they are in IIBHT or they are in wraparound. And those are also maybe something that it's like the goal is to have more in-home community-based services, which is I think our communities in Eastern Oregon are doing fairly well at. And then we still have kids who escalate past that and end up needing to be in the emergency department. Just saying that's a piece is like how many of our RAP and IIBHT kids are also, I mean, I can tell you because I keep those numbers, but like other people may not be able to tell that as like how many have tried other things before they ended up there.
Another variable that sometimes I think is very prone to misinterpretation is that metric about unmet need for mental health services that comes from the National Survey of Drug Use. So you read that question and it very much sounds like an access question. Like, who are these kids who are depressed and aren't getting treatment? That sounds like an access problem. But actually for that question, they actually did a follow-up and they asked, well, why didn't you get that treatment? And by far the number one reason for youth is because they thought they should handle it themselves. So this is what I'm talking about. This isn't an access question. This is a stigma question. You could have all the mental health workers in the world, and that metric isn't going to get better because it's about stigma. It's not about access. And I think it's just another example of how we want to make sure that we're interpreting these data points correctly when there's multiple ways that some of these statistics can be used.
Dave, a question from the chat. Are you talking about the unmet mental health need question?
Yeah.
That one comes from the student health survey.
Okay. Well,
but-
the National Survey of Drug Use and Health has the exact same question. And they with almost the same numbers, but they follow it up with the why. So I would imagine it's the same. It might be similar.
The Oregon Student Health Survey question asks, and I don't have the wording directly in front of me, but it basically it specifically does ask students, was there a time in the past year where you wanted to see a mental health provider, counselor, therapist, but were not able to? So it speaks a little more to access than it sounds like the national one does.
Okay. Yeah. I'll take a look at that. Thanks for the
Yeah,
clarity.
but I mean, the point stands that we do, as we see things trending in one direction or other, as we're learning a little bit more about system performance, we really do need to kind of dig deeper when we see something that's alarming or concerning or positive as to the why questions, because you can go wildly in all different directions based on the way you interpret it. And that's really the function of this committee and other people who think like this group.
Based on the feedback today, what I'm hearing is that what we would like for me to do with this report is, where possible, do basic stats or like a simple year to year of if it's statistically significant or not. And add caveats on a lot of these data points that were brought up from Hillary and from David on what conclusions we actually can and cannot draw from this report.
Yes, and I really do think we should say these couple things jumped out at us. We don't quite know what the meaning is yet. We're digging into that meaning. I caution us. I think we can just make a blanket statement that says this is a first report. We're dialing it in, people. But if you have a report that has 1,000 caveats in it, nobody gives it any credibility at all. And maybe it doesn't have a massive amount of credibility yet, but I think if we express, here's what we know, here's what we don't know, we're going to get better, smarter, faster, then that's honest. I don't think you need a detailed caveat on every little thing because nobody's going to read it. That's just my own view.
That's fair. Thanks, Andrew. And the target audience for this is not academia. It is for our legislative update.
So does that mean you're going to condense it down to 5 or 6 things to put in that update? Because it's going to be a bit too long for legislators to work their way through.
5 or 6 words?
Well, maybe.
Just kidding.
No,
just kidding.
I
to
think
any
we're
of our
talking about. I think we're talking about
current.
leaving all the information here, but just having a summary section.
Mm-hmm.
I don't think you need to start cutting stuff out. I think that's my view.
Yeah. So just so you know, the goal here was so this is how the council was meeting its goals portion of the legislative mandate for the September 15th report. And we're really, historically, I just sort of have drafted this report, and then the State Agency Standing Committee, or what has been reborn as Program and Policy, would kind of dig in and make recommendations, and then the full council would approve it, and I would send it out. But because we have the strategic plan that has all these measurements, and it isn't just sort of like a vibes check anymore of how well we're doing at meeting our goals, we have some numbers that we set out that said these are our goals to make movement in these numbers, and so now we have them to reflect back on. We wanted to use the wisdom of this committee to make some recommendations. And then that's, I'm here, Sean, our communications director, is here. We're here to listen for how do we boil it down for that 1-page summary that we're also required to submit to the legislature that says, here's what's contained in this report on the high points for you, because we recognize you're all very busy, important people. But it will all get published online so that the data will be there as backup for the people like you all who are curious about like, okay, they said they're making progress or they said they're not making progress, but what do they mean by that, right? It's pretty easy to say whatever you want to say and make the statistics back you up. But in this case, we're trying to be transparent and really honest about like, can we measure progress yet? It's the first year of the strategic plan, or, this is what we're looking at, and kind of opening up for questions and conversation from you all as we move forward. Was this the right way to do it moving forward? Because we're trying a whole bunch of new stuff this year. So that, Andrew, is like, we'll do that summary piece, but this is the sort of almost like the appendix of like, okay, here's what the summary is based on. Does that make sense?
Makes sense to me. So do we have to vote on something?
Well, I think next on our agenda would be voting to approve this with the changes and amendments that have been discussed today. And if folks have concerns, I'm happy to. Sorry, my cat has decided it's time to rub his face. If folks have concerns or want to see that last version, I'm happy to have that conversation with you independently as well. But I do think we can probably vote to. I don't even know the formal word. Vote to like send this to our legislative writing process. No. Anna, how would you describe what we're sending this to?
Sending it over to program and policy for a review, and then it'll go to final in front of the full council for full review on September 15th, and then a final vote full review on September 1st, final vote September 15th. Assuming it passes that vote, I will submit it later that day because it is actually due September 15th. If it doesn't pass that day, we'll send a different letter that says the report is not finalized yet, and we'll submit it late. No one has ever died because someone submitted a late report to the legislature.
Yeah, and we're saying we're voting to move this along in the way that Anna just said, with the suggestions that were made being incorporated into it. And I know that it looks like Hillary wants to see a version. Probably everybody wants to see a version. I don't think we can vote by email. So I think we've got to vote here. So can I call the vote? Because it's 5 minutes.
Yes, if you are confused if you're a voting member or not, I am sharing our voting member screen. I hope.
So are we accepting that some of the numbers might not be final? Because I know the MRSS numbers should be with you before the end, and we might have to change the wraparound numbers. So folks might find that is all shifted, as long as that's okay. And yeah, thank you.
Updated numbers in areas where needed. Summary section gets sent over to the policy people that Anna was talking about. If you are in favor of that, please raise your hand, your little virtual hand. I'm raising my hand. I don't know, Anna, Cody, Christy, do we need to call people's names out in this one, or are we?
We don't.
Okay, so we are relieved of that. It looks like I see hands from everybody that I think is a voting member. I don't know. I'll let somebody else figure that out, but it looks good. I don't see anybody with the frowny face just yet.
No, I'm trying to cross-reference too to folks.
Yeah, the one, Anna, when someone is filling in for a voting member, are they able to vote or no?
Hold, please.
Just Amanda Rivers, I'm looking at you just to make sure we're recording accurately.
Sounds good. You can count me in if so.
While Anna checks this,
I count 13.
Okay.
13 hands.
Thank you, Grace, for your chat as well. Okay.
Yeah, we
Thank you,
count,
everybody.
we can count proxy votes in subcommittee.
So that'll be
Perfect.
Hooray.
14.
Okay.
Yeah. I think we did it. I think we got the vote. Again, we're in the very early stages of what will be an increasingly, hopefully, robust analysis process. But I think we all know where we are at this point. You can lower your hands unless you have questions.
In our last 2 minutes, I'm going to jump in and really quickly. I don't think there's anyone here for public comment, but this would be your time. All right, not seeing anything. Next month we'll be revisiting this measure discussion too, and hopefully jumping into maybe some updates that we'll have discovered in this next month on changes that will need to be made in the future. Are these measures what we want them to be? How do we change them moving forward if necessary? I appreciate everyone being here today. This was great. Andrew, Jackie, thank you to my fearless co-hosts. Great work, team.
Thanks, everybody.
Thanks.
See you next time.
Hey, y'all.